Adenocarcinoma of the small intestine is most commonly involving the jejunum when you compare with the rest of the body or rest of the GI tract, and they're more common in the fourth and the fifth decade. And those patients who are immunocompromised or who has the background of some chronic GIT pathologies, then there is more potential or risk for the development of these adenocarcinomas, and they are obviously the malignant and they're epithelial in origin. So other diseases which are related to the development of the adenocarcinoma of the GI small intestine is celiac disease, or you can say the Crohn disease as well, and the familial adenomatous polyposis, hereditary non-polyposis colon cancer, and Pettiger syndrome. So obviously these are the chronic illnesses in which there is a lot of scarring and fibrosis, and because of the increased cell turnover and hyperplastic changes, there is a possibility of development of these tumors. And obviously it's not that they're the only pathological phenomena which are responsible or contributing to these adenocarcinoma is the chronic illness, but there can be mutations at the level of the chromosomes, and there are some teratogenic effects, or there are some kind of environmental and genetic mutations as well, which are responsible for the development of these tumors. So when you talk about the clinical presentation, there are some early cancers and some late cancers. So in early cancers, the patient can have a diffuse anemia. Just anemia, and there's no history of hematomasses or weight loss or malignancy, and just just the hematomasses or melena. This is not much common, and the patient present to you with the anemia, and because when you try to investigate and you send stool for a KELD blood, that came out to be positive, and then you suspect the adenocarcinoma. So anemia or GIT bleeding in the form of the hematomasses or melena can be one of the clinical presentation, or a patient can present to you with a complication, maybe a mass which is trying to cause it up because it's central in the portion, and there is a possibility that the part of the intestine may invaginate into the other part, which is called as an intussusception, or a patient can actually present to you with the signs and symptoms of obstruction. But most of the time, they present with anemia and obviously the anemia, hematomasses, melena, or weight loss. And when you try to investigate such a case, you ask for the history of a weight loss, you ask for anemia, you start from very baseline investigations, like you go for a blood CP. Obviously, the patient would have less hematocrit, and there would be iron deficiency anemia in case of the tumor-related anemia, and then you have to send a stool for a KELD blood. And then maybe possible you do a CT scan if there's a diffuse fibrotic thickening or mural thickening of the intestine, or maybe possible there's a well-defined mass which can be seen in a triple contrast CT. Then you can go for endoscopy, okay? And for endoscopy, if there is a mass or there's a mural thickening, then you just have to take a biopsy, and usually you get the result of biopsy in 14 days, and then that's how you diagnose a case of the adenocarcinoma. And if that comes out to be adenocarcinoma, then you have to plan for the resection wherever the tumor is present. And then you have to see for a metastatic disease, okay? So you have to screen, you have to go for a chest x-ray, you have to go for ultrasound pelvis and kidney ureters and bladder, you have to see them. You have to see for a liver function test, okay, for any kind of a liver metastasis. And if the patient has already in a late stage, when the tumor has already been metastasized, and multiple may be possible, there is the other organs like the portal or veins have already been abutted, or their solid organs like spleen and liver, they have been abutted, then internal ilex have been abutted, then it's obviously not curable, and then you have to put your patient on a chemo and a radiotherapy. Okay, so talking about the options we have available depending upon the site of the tumor, if a limited portion of the jejunum is involved, then you have to resect. You need to resect at least 5 centimeter of the margins should be obtained, because see if there are different kinds of protocols or guidelines when you're trying to resect a particular tumor. So when you talk about these adenocarcinomas of the small intestine, you have to leave a tumor margin free of at least 5 centimeter, a visible tumor margin of at least 5 centimeter, and then obviously you have to go for the other condition. But the tumor in which the allocecal junction is involved, then you have to go for the right hemicolectomy and just do the primary anastomosis with the rest of the maybe possible. This is the terminal ileum, and you are doing the primary anastomosis with the proximal ileum with the transverse colon, and that's how you do. But in case of the jejunum, you will have to resect the jejunal portion, and then just have to do the primary anastomosis and a single layer extramucosal, or you do the double layer and mucosal and serosal anastomosis. That's how you can do the tumor. And then obviously the screening of the patient is very much important. Again, ask for at least initially 6 month screening, and then obviously the for especially when there's a background of the hereditary polyposis, a Pichegger syndrome, or Crohn's disease, then you have to ask your patient or call your patient for the regular follow-ups. This is somehow very, very much important.